for oxygenation. This section will be focusing on ARDS, and then the second PowerPoint will go over chest tubes and pneumothorax. I also want to just mention before I forget that in order to gain attendance, that you attended this lecture and listened to it, etc., I have an online assignment for you guys that is listed under the forum section on your e-learning site. So I believe it's all the way down at the bottom underneath the online meetings tab. And in the forum section, you will see a discussion board that has a few questions about oxygenation and ARDS that I would like you to please take some time and answer. And also, once you submit your answers, I would like you to please also respond to 2 of your classmates. So, you can give your professional opinion or, just discuss something that maybe they didn't mention in their answer that you thought is also important that goes along with the questions. Just things like that to sort of gain the most experience out of it and get opinions from one another, or maybe easy ways to remember things, just to help each other out. So once you respond with your own answers to the questions, then you need to respond to 2 of your classmates. All right, so to their discussion, you just have to write a little response, just a few sentences long. And once you have completed that assignment, then I will put your attendance as present for this lecture. So your concept definition. So oxygenation refers to the process of providing cells with oxygen through the respiratory system, and it's accomplished by pulmonary ventilation, respiration, and perfusion. So you see the definitions of each of those listed down below. So ventilation is the movement of air into and out of the lungs. So that's the ability of you to get air in and out when you take a breath. And then respiration is the gas exchange between the atmospheric air in the alveoli and blood in the capillaries. So the alveoli that are in your lungs, the small little sac-like structures in your lungs that provide the gas exchange when you breathe air in, and that air is, brought into your lungs, and it comes into contact with the alveoli, and that oxygen that you're breathing in is then passed on to the blood that is being perfused through your pulmonary capillary beds, and your gas exchange occurs. Okay, so then the oxygen can jump onto the hemoglobin and continue its way through being perfused through the lungs and into the heart and out into the rest of the body to feed all of the rest of the cells and tissues in the body with oxygenated blood. So respiration is the gas exchange. And then perfusion is the process by which oxygenated capillary blood passes through the body tissues. So we've talked a lot about perfusion, and this is simply stating that the blood that is then oxygenated through the alveoli and the capillary beds gets perfused out through the heart, and the left ventricle pumps it out to the rest of the body to provide its nutrients to all the cells and tissues. Scope of the concept. So hypoxia is going to be when someone does not have enough oxygen. Okay, so the amount of oxygen that is circulating in their arterial blood is low with hypoxia. Okay, so patients who are hypoxia, you're going to see that the patients are going to act restless, they may be very agitated, have a change in their mental status, become confused, diaphoretic, tachycardic, tachypnic, and hypertensive. And if the hypoxia is not reversed and their O2 levels continue to go down, then a late sign of hypoxia would be the cyanosis. Okay? So that's your hypoxia, low levels of oxygen circulating in the arterial blood. Adequate oxygenation, so that's adequate ventilation, respiration, and perfusion. So that is sort of like your normal ability to perfuse your oxygenated blood that your lungs have taken in and exchanged the gas exchange, and you can perfuse your body and keep up with the metabolic demands. And then hypercapnia is when someone is retaining carbon dioxide in their arterial blood. So they're retaining CO2. Okay, so hypercapnia is high CO2 levels in the arterial blood. So when patients are hypercapnic, they are going to present a little bit differently than those who are hypoxic. They may also have a change in mental status, but they're more or less going to be more drowsy, more lethargic even, maybe have a tough time waking them up. If their CO2 levels are high enough, they may be pretty somnolent. They may also have a little bit of restlessness. They may complain of a headache. They'll have more or less a slower respiratory rate. And, if this is not reversed, then they could possibly end up with a coma and could die from it. The typical patient that I think of when I think of hypercapnia is like your overdose patient. So if you have a patient who has overdosed on opiates or something, their respiratory rate gets really slowed down, so they're not ventilating well, which then means they are not going to be adequately exchanging gases with those respirations. And because of that, their CO2 levels rise, and it makes them even more somnolent and more difficult to wake up. So it's very dangerous if it's not taken care of. I also think of your COPD patients too. A lot of times your COPD patients will retain CO2 in their arterial blood. Lifespan risk factors. So this is just in general oxygenation. What are the risk factors for inadequate or poor oxygenation? So infants, you can see listed there: aspiration, choking, rapid respiratory rate. And with preemies, they have decreased surfactant, so their lungs are not well oiled per se. They're more dry, and that makes it a lot harder for your lungs to function normally. So they're at risk for poor oxygenation because of that. Children get common colds, a lot of the childhood infections, exposure to secondhand smoke. Children who are exposed to secondhand smoke are at much higher risk for things like asthma and frequent ear infections. And then the adults and elderly. So as you age, your lung compliance becomes decreased. So that simply means that the ability for your lungs to expand and kind of open up the alveoli with your respirations and allow for that adequate gas exchange. So over time, that ability to expand and function normally decreases and the lungs become more stiff. So as the lungs become more stiff, then you're not able to oxygenate and ventilate as adequately. Decreased cardiac output can occur as you age. So if you have decreased cardiac output, then you are going to end up with poor perfusion of oxygenated blood to the rest of the body. And with elderly, they're at risk for aspiration. And aspiration could cause an injury to the lung, and we'll be talking about that in a little bit with ARDS, or acute respiratory distress syndrome, because aspiration can cause ARDS because it's an injury to the lungs that causes your lungs to sort of malfunction and not be able to perfuse or ventilate well. Factors. Your non-modifiable, so socioeconomical considerations, ethnicity considerations. So this really kind of has to do with, culture. Where do people live? What type of environment are they in? Maybe in developing countries, they maybe don't have the ability to live in areas where they have more access to clean air and things like that. Sometimes some of the poorer populations can be, exposed to pollutants that they're unable to avoid. Personal or family history of lung disease. So there is, genetic testing that can be done, gene-based interventions to look for anything that could possibly be passed down in the genetics from family history. You're modifiable, so risk factors, that's everything that somebody has control over. So that would be things like smoking, again, sedentary lifestyle, obesity. So you can see some of these listed here kind of go hand in hand with a lot of the risk factors we talked about in the perfusion lectures. So a lot of times they're very interrelated. Abstaining from immunizations. So it is found that when people abstain from their vaccinations or immunizations, they're at higher risk for developing lung diseases, for instance, influenza, pneumonia. And if someone has not been immunized, then they potentially could become severely sick if they come in contact with those diseases and get sick themselves. Their body won't be able to fight it off. Air pollution. So this, I know I mentioned a little bit non-modifiable. So the difference here is air pollution modifiable in terms of where do people work? Are they working in factories where they're exposed to, chemical vapors in the air that is going to harm their lungs? The coal miners that are exposed to harmful chemicals when they're in that type of job. So air pollution that you could avoid if you wanted to, but maybe that's just the type of environment that you work in, and that's what your occupation entails. High anxiety and stress. So over time, stress hurts your immune system. So it can make your immune system a little bit more weak if you have high stress levels for a chronic period of time. So your body would have a more difficult time fighting off infections, which could then hurt, if you come in contact with some respiratory infection, your body may not be able to fight it off as well if they're immunocompromised. Opioid use, so I talked about this a bit when I talked about hypercapnia. So with opioids, your respiratory rate tends to slow down. So if your respiratory rate is slow, you're going to be at risk for inadequate gas exchange and end up with the high CO2 levels. Exposure to pollen, environmental pollutants, that kind of goes hand in hand with what I talked about. Recreational and occupational hazards, and excessive exposure to acetaminophen prenatally, and vitamin D deficiency. So vitamin D deficiency, you can take your supplements for vitamin D, or just simply go outside into the sunlight and get vitamin D that way as well. So assessments for these patients. So just in general, health history. Do they have any acute lung problem at the time that you're seeing them? So gaining all of your health history that you would for any other problem that a patient presents with. So onset, location, duration, etc. Common symptoms that you see with respiratory problems would be dyspnea. So dyspnea is when patients feel like they're having trouble breathing. That could also include dyspnea when they are doing activity, or it could be dyspnea when they are laying flat, right? We've talked about that with heart failure patients when they have the orthopnea or paroxysmal nocturnal dyspnea. So, it's not only acute lung problems that can cause dyspnea, there are other things too, such as heart failure. Cough. So if someone comes in with a cough, you want to ask if they have sputum production, get information about the sputum. Is it something that is bacterial that could be occurring? So that would be like your yellow, brown, or kind of green sputum that can occur. That would signify maybe they have a bacterial infection going on. Or are they having frothy sputum that's white and pink tinged and having a lot of it, that would make you think, is this person in pulmonary edema? So you have to assess sort of the differences of what they're experiencing with cough and sputum production. Chest pain can sometimes occur, like pleuritic chest pain. So that's just pain caused by the lungs. So it's not actual chest pain like when you talked about a myocardial infarction with Ginny. It is caused by the pleura in your lungs, and oftentimes these patients will say, like, when I take a deep breath, it feels like I get this stabbing pain on the right side of my chest. So that's like your typical pleuritic chest pain. Wheezing, so you can see wheezing with various diseases. One thing I think of most would be asthmatic patients. So assessing their degree of wheezing, how severe is it? Is it chronic for them? Is it something acute that is occurring? Hemoptysis, so that is, coughing up bloody secretions. Hemoptysis can occur from a lung injury, whether it be like a chemical injury or like a physical injury, or maybe someone has lung cancer. That can also be another cause. So psychosocial factors, quality of life, so that kind of goes back to the risk factors when I was discussing, what are they exposed to in their lives, whether it be occupational or socioculturally, in terms of where do they live, what type of environment do they live, do they have the option to kind of get out of a bad environment in terms of pollution, or is that where they have to stay, and what can you do to help them in terms of preserving or protecting their lungs when they have to be exposed to certain pollutants. Ability to carry out ADLs. So are these patients able to care for themselves at home? This kind of goes hand in hand with what we talked about with heart failure patients too. So if they're having restrictions with their lungs, meaning they feel as though they can't catch their breath, or they get too short of breath with activity, things like that, you want to assess to see, are they able to be independent at home, or are they having a hard time because their breathing is restricting them from carrying out all of their activities of daily living. And then your critically ill patient assessment. So I'll kind of go through this in the upcoming slides when I talk about advanced airways, but critically ill patient assessment, oftentimes, I'm not going to say always, but oftentimes these patients are requiring an artificial airway, such as a tracheostomy or an endotracheal tube. And these patients have to be cared for very closely because their airways are at very high risk for, compromise or, failing, I guess, if you want to put it in that term. So they have to be watched really closely when they are critically ill. So respiratory failure for your critically ill patient. So advanced airways, so it's endotracheal intubation that I briefly mentioned a second ago. So endotracheal intubation, I don't know if any of you have ever been able to observe somewhere, maybe like in a clinical, if you've been able to observe ICU or you work in an environment where you see critically ill patients in an ER or an ICU or maybe even OR. So endotracheal intubation is more your short-term advanced airway. All right. So endotracheal tubes go in through the oral cavity, so through the mouth, and they are placed through the vocal cords and down into the trachea, into the main stem bronchus. Okay, so down into the main stem of the lungs, the bronchus. So the endotracheal intubation is oftentimes done by a physician or an anesthesiologist or someone who is qualified to intubate somebody. So nurses do not place endotracheal tubes, okay? This is something that has to be done by a licensed practitioner. So with endotracheal tubes, I mentioned that they are short term. Okay, so these are your patients that maybe come in with respiratory failure, say to the emergency room, and maybe they're a patient who has really bad COPD, and they can't catch their breath at all. They're not exchanging any air when they try to breathe, and their gas exchange is extremely poor. So respiratory failure can be classified as a oxygen level in your arterial blood is less than 50, and the CO2 level in your arterial blood is greater than 50, and your pH is less than 7.35. Okay, so that's kind of like your classification for respiratory failure. So if you have a patient who comes in who is a bad COPDer and you check their arterial blood gas and you find that their pH is less than 7.35 and their PaCO2, so that's the arterial CO2, is greater than 50, and their PaO2, which is the amount of oxygen in their arterial blood, is less than 50, then you are very concerned for this patient because they're exhibiting respiratory failure. So if this were someone who just came in, you wouldn't be able to just leave them like that and just put some oxygen on them and hope they get better. They most oftentimes will need some support with mechanical ventilation through an endotracheal tube. So in that case, the physician or whoever, is there in the hospital who performs the endotracheal tube intubation, they'll put that breathing tube in. Okay, so again, it goes through the oral cavity, and it goes down through the vocal cords into the trachea, and then it sits in the main stem bronchus, okay? So once it's in, and don't worry, you guys will get to see the difference between endotracheal tube and a tracheostomy tube in your simulation that you have. We have different tubes just so you can see like what I'm actually talking about here in this lecture to help visualize it. But when this tube is in, it's going to be short term, maybe up to about 2 weeks. So I know where I work, the maximum that somebody will be intubated with an endotracheal tube is 14 days. Okay, so that's my kind of like 2 week period that I know if my patient has not been able to be taken off of this endotracheal tube ventilation by 14 days, then we're going to be looking into something more long-term. And more long-term is going to be your tracheostomy. So your tracheostomy tube is surgically placed, okay? So that's done in the operating room, okay, when it's a controlled situation. It'll be done in the operating room, and the tracheostomy is put into the patient's anterior neck, okay? So you've probably seen a tracheostomy, whether it be in your clinicals or workplace or maybe even just in shows on TV or something. So it's placed in the anterior neck, and it's placed directly into the trachea, surgically placed by a physician, and it can stay there for a very long period of time. People can live with tracheostomies, for the rest of their life if they need to. So the difference between the two is that endotracheal is short term and your tracheostomy is more long term. All right? So when you have patients with an advanced airway, whether it be endotracheal or tracheostomy, one of the big concerns is that you want to ensure that their airway is going to stay patent. Okay, you want it to stay open. And one thing that could possibly, just as an example, block one of these artificial airways or advanced airways is secretions. So if somebody has a lot of sputum secretions, then we as nurses need to be sure that we are clearing those secretions from their advanced airways by suctioning them. Because if we don't, then we run the risk of the sputum sort of congealing together and causing a mucus plug. And when a mucus plug happens in one of these advanced airways, it can be really dangerous because then air cannot get into the lungs and cannot escape the lungs, so the patient can't breathe. Okay, so it basically blocks their airway if they end up with a mucus plug. So as nurses, we want to perform, meticulous care in terms of listening to lung sounds. You want to hear if you want to listen to see if you hear any adventitious sounds. So that would be like if you hear rhonchi or rhonchorous lung sounds, you might think that they have some secretions rumbling around in there. And you want to clear those secretions by suctioning them. And for those of you who have not yet seen suctioning of a patient with an advanced airway, I'll explain it a little bit because it is important to know. You may not see endotracheal tubes being suctioned just because, again, that's your ICU level patient who's critically ill. But tracheostomy tubes, you may have a patient with a chronic tracheostomy on a regular medical floor, and you have to know how to suction these patients to keep their airway patent. So when you go to suction patients with an advanced airway, you do want to listen to the lung sounds, okay? You want to be sure that you listen to hear for those adventitious sounds, something that indicates that they may need suctioning, which would be like coarse, rhonchorous lung sounds. Other things that may indicate they need suctioning would be a dropping O2 saturation level. If they've been saturating fine, and all of a sudden you notice, their sats are dropping a little bit here and there, they might need a suction. There may be some secretions blocking a little bit of their airway. So you want to listen and figure out if they need suctioning. Okay, if they do need suctioning, then what they typically recommend is hyperoxygenating them. So that simply means give them 100% of oxygen. Okay, if they have an endotracheal tube, you will have them hooked up to a mechanical ventilator, and you can simply just push a button on the mechanical ventilator that gives them 100% of oxygen. Okay, if you have someone with a tracheostomy who's not hooked up to a mechanical ventilator, then you can put oxygen over their tracheostomy tube via a trach collar or, something along those lines, a little trach mask there, and supply them with high amounts of oxygen before you suction. So when you have hyperoxygenated them or pre-oxygenated them, those two words mean the same, so you give them the 100% of oxygen. You'll then get your suction catheter, and this is a sterile procedure, okay? So if you have a chronic trach that you're suctioning, you're setting up your whole little sterile field, okay? Because this is a sterile process. When you stick that suction catheter into the advanced airway, whether it be a trach or an endotracheal tube, you want that catheter to be sterile, because if you introduce a catheter that is not sterile and maybe has something, I don't know, maybe it swiped across the bed and it picked up some bacteria that was on the bed, and then you go and put that down somebody's endotracheal or tracheostomy tube, you're just putting all that bacteria into somebody's lungs. So just remember that it's a sterile process. Okay, so let's get back to the steps. So you've listened to your lung sounds, you've looked for a reason why they may need suctioning. Okay, you've hyperoxygenated them with 100% of oxygen, and now you're getting ready to advance your suction catheter. So you advance the suction catheter down the tube, okay, whether it's an endotracheal or tracheostomy. And when you advance that catheter, you're going to hit a point where the patient will start coughing, okay? So that's kind of how you know you've gone far enough. For tracheostomy tubes, it's going to be a shorter distance, because remember, that is a short tube. That tube goes right into the anterior neck, into the trachea, right there. And they're about maybe 4 or 5 inches long, so they're not that long. Your endotracheal tubes, the ones that go through the mouth and all the way down through the vocal cords and into the trachea that way, you can imagine that is going to be a longer tube, because it has to go from the mouth to the larynx, to the trachea, and into the lungs, right? So with those tubes, you're going to be advancing your suction catheter a little bit longer, a little bit further to get that coughing response. So once the patient begins to cough, you then will apply your suction and withdraw the suction catheter. So when you're withdrawing the suction catheter, you do not want to take any longer than a maximum of 15 seconds, okay? Generally, they say 10 seconds, but I have seen in some places that says 10 to 15. So just know that absolutely not over 15 seconds when you are withdrawing the suction catheter. And the reason for this is because as soon as you push the suction button and apply the suction to their airway, you're basically taking away their breath and their oxygen. So you don't want to do that for a long period of time. Okay? So again, a maximum of 15 seconds when you're withdrawing the catheter. On average, it's going to be 10 seconds. But it's kind of just keep in mind, it's a slow and steady withdraw the catheter until the catheter's all the way out of the airway. Okay, if you have a trach patient, you're going to kind of swirl the catheter on your way out. So you do little circular motions with the suction catheter. That's just to get all the secretions that could be sitting on the inside of the tube. But you do not have to do that for endotracheal. So it's just the tracheostomy tubes. When you withdraw, you kind of do it in a little circular motion, so your suction catheter is hitting all the sides of the tube when you're coming out with your suction. All right. So during this process, once you have pulled that suction catheter out and you've performed your suction and you are done, you want to then reassess your patient. So if they're on a monitor that's in front of you, for instance in an ICU with a critically ill patient, you can look at their monitor and look at their O2 saturation, look at their heart rate, look at their blood pressure, so you can kind of see if they may be having distress after suctioning. Maybe they became hypoxic, right? So if they're a little bit hypoxic from all the suctioning, Their heart rate might go up a little bit, become tachycardic, and they may just need a little bit of extra oxygen until they settle down again. And you also want to take another listen to their lung sounds, because you want to hear if those chorus ronchorous sounds that were present before suctioning have gone away. Because if you've suctioned the secretions out, then your lung sounds should sound better. Okay? So I know that was a lot of talking for the suctioning process, but you can also find it in your Hinkle book as well. So it goes through very similarly what I just discussed. So also with advanced airways, if they are connected to a mechanical ventilator that is breathing for them, there's something called ventilator-associated pneumonia. Okay, VAP for short, that you can see there. So with ventilator-associated pneumonia, this is something that just simply means what it says. The patients are on a ventilator through an advanced airway, and that puts them at risk for developing pneumonia. So it's our job as the nurses to try our best to prevent pneumonia from developing. So there are actually VAP bundles, or ventilator-associated pneumonia bundles, that have been created for facilities to use when they are caring for critically ill patients on mechanical ventilation to help prevent the development of pneumonia. So these oftentimes will include things like keeping the head of bed greater than 30 degrees. Okay, so head of bed greater than 30 degrees. You also want to be sure that you provide frequent mouth care. So depending where you work, the time frame can vary a little bit, but on average, it's every 2 to 4 hours they should be receiving mouth care. So every 2 to 4 hours you receive mouth care. You also want to be sure that they are on some form of peptic ulcer disease prophylaxis. So that would be like your pantoprazole or your Pepcid, so your PPIs. So you want to administer the peptic ulcer disease prevention to these patients because their body is under a lot of stress when they're critically ill, and that puts them at risk for the development of an ulcer in their stomach or their gastrointestinal tract. So we try to prevent that from occurring by giving them peptic ulcer disease prevention. So that's like your PPIs, your Protonics, your Pepcid. Okay? So you have the head of bed greater than 30. You have your mouth care every 2 to 4 hours. You have your peptic ulcer disease prevention. Then you also have your DVT prevention. Okay, so you don't want them to get a DVT while they are on bed rest when they're critically ill. So these patients will oftentimes be on like subcutaneous heparin or subcutaneous Lovenox while they're on bed rest, mechanically ventilated, and critically ill. Okay? So one other component that I want to mention is their sedation. So when patients are mechanically ventilated, they will be on some form of medication to either keep them sedated, okay, like basically like anesthesia to keep them sedated. Sometimes also pain medication, analgesia, all right? So when they are sedated, another component of this VAP prevention bundle is the ability to give them a break from their sedation daily. So sometimes this is called a sedation vacation, which simply means that you lower the amount of sedation or you shut off the sedation excuse me, that the patient is receiving in order to wake the patient up a little bit to be sure that you are assessing them for signs and symptoms of delirium. Okay, so you kind of wake them up, you ask them, to squeeze your hand with certain questions to see if they answer it appropriately. You're kind of gaining a sense of what their cognitive status is. Okay, so once they are sort of awake and their sedation has either been decreased or shut off, then we also try to perform what's called a breathing trial. So when someone's on a mechanical ventilator, it's breathing for them. Okay, the ventilator has specific settings that the physician has prescribed, and the ventilator kind of just, delivers the breaths at the amount of breaths it's set at, gives the amount of volume it should, the amount of pressure, everything's all set a certain way, and the ventilator does pretty much all of the work. So with breathing trials, sometimes called spontaneous breathing trials, with these, the ventilator mode is changed a little bit. So the settings are changed so that the ventilator isn't automatically providing all of the work for this patient's breathing. So the settings are changed in a way that it allows the patient to do the breathing on their own. Okay, so they're still hooked up to the ventilator. It's just the fact that these settings have changed. So this way the patient will be taking their own breath and taking in their own amount of tidal volume, and the ventilator is not just programmed and set at a certain specific number that keeps delivering, minute by minute what is prescribed. Okay, so hopefully that makes sense a little bit. So that's how you help to prevent ventilator-associated pneumonia. So that's a bundle that, I would like you to be familiar with because, it is pretty widespread that a lot of hospitals and facilities are using some sort of ventilator-associated pneumonia bundle to help prevent it from occurring in critically ill patients. And also, some other care that comes to mind with patients with advanced airways is their safety, right? So if you have these patients who have an artificial or advanced airway in, you don't want them to pull those airways out because they're in there for a reason. They either have respiratory failure, maybe they have an obstruction somewhere, something's wrong, that they need these airways in order to maintain a patent airway and breathe. So safety is a huge component of care for these patients. So we want to be sure that we are maintaining their safety by, sometimes having to maybe put wrist restraints on these patients so that if the patients do wake up a little bit, they can't reach right up and pull these tubes out, because that can happen. I have seen it happen where I work, where patients will be somewhat awake and they're agitated and the nurse isn't in the room, and next thing you know, the ventilator is giving you all these sorts of loud alarms beeping because there's been a disconnection, and the disconnection is that the patient reached up and pulled their own tube out. So safety is huge for these patients. And also, with these patients, it's hard to communicate with them because if they are endotracheally intubated, then that airway is going through their mouth, right? So they can't talk. It's hard for them to move their lips well enough. Sometimes you can lip read, but it gets frustrating for the patient a lot of times if they're awake enough and they're trying to talk to you and tell you something or maybe ask you something. So you have to sometimes be creative. And what are you going to do to communicate with these patients. And that same goes for tracheostomy patients too. Sometimes, tracheostomy patients are unable to make any sound. So you have to have a way of communicating with them. So there are things like communication boards that facilities will have that kind of have like the common issues that may arise, like pain, toilet, hungry, thirsty, simple things like that a patient can point to on a board. Or sometimes they even use whiteboards and have the patient write something down, or a clipboard with paper and pencil. So you have to just have ways of communicating. And a lot of times, keeping questions simple, like simply asking yes/no questions, the patients are able to nod their head, yes, no, which can make communication a little bit easier as well. So mechanical ventilation, to go forward here, you have non-invasive positive pressure ventilation. So non-invasive simply means what it says. This is not an invasive procedure that physicians have to do or whatever. It's non-invasive. So with these modes of positive pressure ventilation, there's two that are called BiPAP and CPAP. So BiPAP is short for bi-level positive airway pressure. So bi-level positive airway pressure. That's your BiPAP. And this is like a mask, like a big mask that goes over the nose, from the bridge of the nose, over the mouth, down to the chin. And that big mask is held on by some big straps that go around the head. And it's held on pretty tight. And the same thing is very similar with CPAP. So CPAP stands for continuous positive airway pressure. And CPAP can either be a mask, like I just described, or sometimes can even just be a little nasal mask or nasal prongs for CPAP. So with these two modes of ventilation, they're non-invasive because they are simply masks that are put onto the face. Okay, so there's nothing invasive occurring there. So with BiPAP, the bi-level positive airway pressure, the BiPAP machine is set up to deliver a certain amount of pressure with each inspiration and each expiration. Okay, so it delivers some pressure when the patient initiates their breaths. And this helps to open up the lungs and open up the alveoli so that someone can oxygenate a little bit better. So with BiPAP, patients can also have a respiratory rate set on their ventilator, on the BiPAP ventilation. So if you put BiPAP on someone, maybe again, I keep going back to this overdose patient because that's what comes to mind with a lot of these things. If you have someone who's taken too much opioids and their respiratory rate's really slow and their CO2 levels are very elevated and they're very lethargic, you can put them on something like BiPAP, the mask over their face, and they'll breathe, at their own slow rate. But if they breathe too slow, then that ventilator knows to give them a little breath. Okay, so it knows to administer a breath if the patient does not breathe on their own. Okay, so your CPAP is a little different in the sense that patients have to be breathing spontaneously. So CPAP, patients have to be breathing spontaneously. So CPAP can be used in a hospital setting, and it can also be used at home. Sometimes patients who have obstructive sleep apnea, they may need CPAP to sleep at night because that continuous positive airway pressure helps to keep their airways open at night so that they can breathe when they're sleeping and they do not become apneic. All right, so that's sort of a little bit of a difference between the two. The BiPAP can deliver breaths if it needs to, all All right, so that can be like your really somnolent patient. It would be good to use for. And then your CPAP is someone who needs to be breathing spontaneously. So that would be like your obstructive sleep apnea patient. Sometimes CHF patients will also need CPAP just to help with their work of breathing. That little extra bit of pressure helps to sort of open those lungs and alveoli so that they can better oxygenate and better perfuse oxygenated blood. Okay, so that's your non-invasive positive pressure ventilation. The invasive positive pressure ventilation is what I was talking about with your advanced airways. So invasive, meaning that something had to be placed in somebody in order for it to work. So the endotracheal tube goes through the mouth and down into the larynx, into the trachea, and then your tracheostomy is surgically placed into the trachea through the anterior wall of the neck. So that's your invasive. So those patients, when they have advanced airways, can be attached to a mechanical ventilator, and the ventilator, like I described earlier, will administer its set pressure, its set number of breaths per minute, and its set tidal volume for each breath. All right? So I talked a lot about that already, so I'm not going to stay on that too much. But that's the difference between the different types of mechanical ventilation. One is non-invasive and the other is invasive. So when you have someone on a mechanical ventilator, there are certain alarms that you absolutely need to know. So put a little star next to them. So mechanical ventilation alarms. So low pressure. So this means that somehow air is escaping the system. Okay? So I don't know if you can see in the little picture here on the screen, you can see sort of like those blue and white tubes that go from the mechanical ventilator machine and they go towards the patient, and that's hooked up to an endotracheal tube there. So low pressure means that there's an air leak somewhere. So maybe one of those tubes became disconnected somewhere. And when that ventilator tries to give a breath to the patient, the air is escaping the tubes and escaping the system. And the ventilator can pick up on that and alarm to let you know something's not right, that there's low pressure, there's a leak somewhere in the system. So that can be because of disconnections. Okay, if a tube becomes disconnected somewhere along the line, maybe the tube actually gets disconnected from the advanced airway. Okay, so that would be a low pressure. Other things that could cause that is sometimes patients, when they have the endotracheal tubes in their mouths, if they are awake and agitated, they can potentially bite their tube. So they could make a little hole in their endotracheal tube in the balloon that holds it in. And that would cause air to escape when the ventilator tries to give a breath. It'll escape, it won't go into the lungs like it's supposed to. It's going to escape around that broken endotracheal tube. So those are your causes of low pressure. So there's a leak or a disconnection somewhere within the system. Your high pressure is pretty much the opposite. So high pressure is when there is a high amount of pressure within the mechanical ventilator system. So that could be caused by someone biting on their tube. Okay, so they're obstructing the tube somehow. So if a patient's biting on that tube and the ventilator goes to push a breath in, it's not going to be able to because that person is clamping down on the tube. So there's high pressure there. There's a blockage or an obstruction. So that's one example, is biting. Other things that would cause high pressure would be things like a lot of secretions. So remember earlier when I was talking about a lot of secretions, if they build up over time, then they can turn into a mucus plug and block off the airway. That's going to alarm high pressure because the mechanical ventilator is not going to be able to give its breath that it wants to give to this patient. So it alarms and lets you know, I can't deliver this breath. There's high pressure, high pressure. So as a nurse, you need to assess what's causing this high pressure. Okay, you need to assess the patient. And if you're unable to figure out what is causing either a high pressure or a low pressure alarm, and the mechanical ventilator is not ventilating your patient, that could be very serious. So you don't just wait to figure out what's wrong with the ventilator. At that point, you would have to disconnect the patient from the ventilator and put an ambu bag on their advanced airway and just bag the patient with the ambu bag until you could figure out what's wrong with the ventilator. Okay? So if there ever comes a time where patients are just alarming, low pressure, or high pressure, you can't figure it out, you've done your assessment, you've looked for leaks or you've looked for obstructions, and you can't figure it out, you don't want the patient to stay like that. You're going to have to disconnect them and put your ambu bag on the advanced airway. Okay, it just attaches right to it, whether it be an endotracheal tube or a tracheostomy tube, it just hooks right up, and you administer the breaths yourself with the ambu bag. Okay, so that's like emergent situations when you need to ventilate your patient. You can't just let them sit there having low pressure or high pressure alarms and not do anything about it. Apnea alarms, so those will let you know if your patient is apneic. So that kind of goes hand in hand with the spontaneous breathing trials I talked about. So when your patients are supposed to be taking their own breaths, if they are not maybe awake enough to, and you've tried the breathing trial and maybe they were doing okay for a little while, so you walked out of the room and a little while later it's alarming apnea. So that is set to let you know if they are breathing way too slow or not breathing at all during their breathing trial. And in that case, we'd have to stop the breathing trial and put them back on the ventilator settings. Okay, so apnea is when they're not breathing. So I know that's a lot of information, but the important things to know is the difference between endotracheal intubation and a tracheostomy. So what is the nursing care for each? So I discussed in the beginning what's really important. So you want to maintain a patent airway, okay? You want to maintain their safety. You also want to maintain some form of communication with the patients, and you want to try to prevent any ventilator-associated pneumonia. Okay? Your mechanical ventilation, there's non-invasive and invasive. The non-invasive are the masks that can be put on, okay, or the nasal prongs or the nasal mask, and that's BiPAP and CPAP. So remember, CPAP, someone has to be spontaneously breathing for CPAP to be effective. BiPAP can deliver a breath if a patient does not breathe at a certain rate that the physician wants them to. Okay, so it can deliver a breath if it needs to. But both modes, the BiPAP and the CPAP, are providing the patient with some positive airway pressure to help oxygenate and open up their lungs and alveoli when they breathe. And your mechanical ventilation alarms, again, important things is to distinguish the difference between them and what would you do as the nurse if you came across a low pressure or high pressure or apnea alarm. Okay? Picture for you to see non-invasive positive pressure ventilation. All right? So these masks here, you can see go over the bridge of the nose, come down by the mouth and over the chin. So oftentimes this is your BiPAP. Okay? CPAP can also be given in this method. All right? But it's a little bit more, cumbersome for the patient. And you can see here, this patient is using his CPAP at home. Maybe he has obstructive sleep apnea and he needs his CPAP, so he wears it to sleep at night. This is your invasive mechanical ventilation visual. So this is your endotracheal tube. All right, so right here on the left, the patient has the tube that is going in through the mouth. All right. So when someone is intubated, this tube here has little marks on it, and you can't really see them at all in this picture, but it has little numbers, so that way you'll know what number is at their lip line. So when someone's intubated, you're going to want to know what is the patient's lip line, and that simply means what number is on this tube right at their lip. And why do you want to know that? Because each shift, the nurse should be assessing it, so that way they can see if the endotracheal tube has moved at all. Okay, if you have a patient who's maybe coughing a lot forcefully, or maybe you have a patient who is trying to reach up and pull at this tube, and maybe they get it a little bit but not all the way, and they pull this out a little, it's the nurse's responsibility to see, like, oh no, that tube was at 24 earlier and now it's at 22. How did that happen? Okay, so that's considered your lip line. So these endotracheal tubes have little markings on them, and the nurse will be sure to check each shift that that marking has not changed. The other thing you can see here in the picture is this big strap that goes across the face and around the back of the neck. Kind of goes over, the upper lip there. And if you could see the other side of him, you'd see it continues on the other side. So that is how the endotracheal tube is secured to the patient. So that is also something we as a nurse want to look at. We want to make sure our tube is secured. We don't want it to move. This is the patient's airway. This is their only way that they can breathe right now. So we need something to hold it in place. So this is just one example of what some of those tube holders can look like. Okay? And then the other thing too that you as the nurse want to do, and I've mentioned a few times, is listen to their lung sounds for any changes in their lung sounds. And when these tubes are initially placed, so say a person comes into the ER, like I was saying earlier, someone who's in respiratory failure, they need to be intubated. Once that endotracheal tube goes in, you're listening to your lung sounds. You want to know that that tube is in the right place. So if that tube was put in, and maybe the physician accidentally put it into the esophagus instead of the trachea, you're not going to hear lung sounds, right? There's going to be no tube there to deliver the breaths into the trachea because it was accidentally put in the esophagus. So that would be a huge problem. So lung sounds are so important for these patients, okay? So that's your endotracheal tube on the left. Then you can see your tracheostomy tube here on the right. So similar concept, except it just goes through the anterior neck. It's surgically placed into the trachea. All right, you can see the trach tie is right here, and that is to secure the tube in place. So we don't want a tracheostomy tube to move either, because if we lose this tube, we lose our airway, and that's a huge problem. So we make sure that our tube tamers are tied. They're secured to the patient. Okay? So that's your tracheostomy tube. So ARDS, so acute respiratory distress syndrome. So ARDS is a failure of the respiratory function due to inflammatory processes within the body. So basically, your lungs are failing. You have respiratory failure with ARDS. There are many different risk factors and causes, and you can see them listed here. Some of the big causes would be aspiration. Okay, remember I talked earlier about an injury to the lungs? So that would be like gastric contents, or maybe it was chemical. All right. I have a story that I can tell you about a patient I had just within the past probably 6 months or so in the ICU where I work. And he was working on his job site, and he did some sort of construction or cleaning at a construction site or something like that, where he had accessibility to different cleaning solutions and stuff like that. So he ended up picking up a water bottle that he thought was juice, and he picked it up and took a gulp of it. And it turned out to be a very strong, unconcentrated cleaner fluid. So imagine what that cleaning fluid did to all of the mucosa in his mouth, his esophagus, and even a little bit into the lungs. So he aspirated a really powerful cleaning solution that just basically caused burns everywhere in his oral cavity and in his esophagus, his upper airway. And he immediately came to the emergency room, and he was unable to have an endotracheal tube placed because of how severely burnt his mouth and esophagus and upper airway was. Everything was swollen shut. His vocal cords were all swollen shut because of the chemical burns from aspirating this cleaner. So they had to emergently place a tracheostomy in the emergency room. So he didn't even go to the OR for his tracheostomy. He had to have it emergently placed in the emergency room because his airway was becoming obstructed from all the chemical burns and the swelling. So he ended up in our ICU for, I think he was there almost a month recovering. And it took him a long time, but successfully he, was able to go to rehab. And he was a young guy. I think he was only in his early 30s. So it was a very unfortunate situation and not something you see very often. But it's an example of how someone can simply accidentally aspirate something that has caused such a traumatic burn and chemical injury to their mucosa that lines their mouth, their stomach, their trachea, and everything. And it causes huge problems. So things like that can cause people to have respiratory failure, and it injures their lungs so badly that they need to be put on mechanical ventilation, and it's a long recovery for them. So aspiration is one cause. Prolonged inhalation of high concentrations of oxygen, smoke, corrosive substances. Hematological disorders, so sometimes if people have like bleeding disorders, localized infection, sepsis, okay, major trauma or shock, any major surgeries, and also embolism, whether it be fat or air embolism. So any injury that occurs to the lungs can potentially cause acute respiratory distress syndrome. So your diagnostic evaluators, so you want to look at BNP levels, all right, because these patients can sometimes have elevated BNP levels related to the amount of stress that the heart has to endure when they are having all of this respiratory distress. So it's not related to simply just their heart failing, like I've discussed with heart failure lecture in the past in BNP levels. It's a little bit different because it's caused by respiratory problems. Echoes, so again, that can look at the heart, and if the heart is under any strain from the respiratory problems. Pulmonary artery catheterization, so that is ICU level. I don't expect you to know that. But basically you can see, on your monitor with a PA catheter, what the pressures are in the pulmonary artery. So, when someone has all this congestion, which is what happens in ARDS, they end up with a lot of fluid accumulation and fluid congestion in the pulmonary vasculature, the pulmonary artery catheterization is a way to kind of tell you how high the pressure is in the pulmonary artery. And again, that's ICU level of care. And then your chest x-ray. So this is important for ARDS patients because ARDS patients will have sort of this classic chest x-ray where they have bilateral infiltrates. So another way to say it is that they have a whiteout on their chest x-ray. So if you remember back to the little case scenario I did at the end of class with my valve lecture, and we went through the little case study up on the screen and the picture of the chest x-ray came up, and it was hard for you guys to distinguish whether it was normal or what was abnormal. So the abnormal chest x-ray, where it looked really fluffy and sort of full of fluid and white, everything was sort of whited out in the lung fields, where it should have been nice and black on an x-ray, it was all kind of white. That's what happens in acute respiratory distress syndrome. But it's not caused because of heart failure. It's caused because of respiratory failure with a lot of fluid and congestion that occurs in the lungs and the alveoli. Okay? So, bilateral infiltrates or whiteout of the x-ray. And I'll post again a picture on the e-learning site so you can see the difference again, just to help visualize, because that's a classic symptom. They'll also have severe hypoxia, right? So remember back in the beginning, respiratory failure. What is sort of the criteria for respiratory failure? Well, severe hypoxia. The PaO2 less than 50. That's really severe, right? We want our PaO2 to be 80 to 100. If you think back to your ABGs when you learned about acid base, your normal for your PaO2 is 80 to 100. So if you have someone with severe hypoxia and their PaO2 is less than 50, that's a problem. They're not oxygenating well at all, which means the rest of their body and all the tissues and cells are not being oxygenated. Decreased pulmonary compliance. So pulmonary compliance, remember in the beginning when I talked about the elderly's ability for their lungs to expand and function and exchange gas adequately, and over time the compliance is decreased. Well, that's kind of the same situation here, except your pulmonary compliance is decreased because of an injury to the lungs. So the lungs become very stiff, okay? So they cannot ventilate well. You have very stiff lungs with ARDS. It's actually quite amazing when you see it. When you have a critically ill patient who is in ARDS, it's very, very hard to ventilate them. You'll hook them up to the mechanical ventilator, and all the ventilator is going to do is alarm high pressure, high pressure, high pressure, because it's trying to administer a breath into this patient, but their lungs are so stiff that the breath can't get in there. The lungs have very poor compliance, okay? Poor alveolar perfusion. So they have increased alveolar dead space. So this means that the air can enter their lungs, but when it's in there and it's supposed to be exchanging the gases with the alveoli and the capillary beds and give the oxygen to the blood so that it can be perfused to the rest of the body, it can't do that. The alveoli are filled with fluid in ARDS. They're so filled with fluid and damaged and stiff that they cannot adequately exchange gases. So that's why we end up with severe hypoxia, because that oxygen comes in and says, okay, alveoli, I'm here to exchange my oxygen and give the oxygen to your hemoglobin so you can carry it to the rest of the body. And the alveoli are saying, nope, I'm not home. I'm not working. I'm not here today. You can't give me your oxygen, and I'm not going to perfuse the rest of my body with oxygenated blood. All right? So this poor perfusion. Patients will also have intercostal retractions. So that just means that they're using, like extra accessory muscles. They're going to have sort of like the muscles within their intercostals that are going to be pulled like in when they breathe. You can see them working hard just to breathe. And when you auscultate their lungs, you're going to hear crackles throughout because they have the bilateral infiltrates on their x-ray. Their lungs are just basically all fluid filled. So you're hearing all those crackles. And it's not because of heart failure. It's because of the injury to the lungs. So your management for these patients: endotracheal intubation and mechanical ventilation. So they need ventilatory support. They're unable to breathe on their own when they have ARDS. I don't want to say that's every single patient with ARDS, because sometimes, if it's caught early enough and treated right away, the patient may only need like a BiPAP, right? So that's your non-invasive ventilation, the BiPAP. They might just need that, and they could get through it and be okay. But for patients who are acutely, critically ill with ARDS, oftentimes they will have the endotracheal intubation and mechanical ventilation. So when they are mechanically ventilated, an important piece of their management is something called PEEP. All right, so you see ventilatory PEEP there. So that's your positive end expiratory pressure. PEEP. So positive end expiratory pressure. So the reason the PEEP is so important for these patients is because PEEP is a setting on the ventilator that is basically how much pressure is going to be delivered to help open up the stiff alveoli in the lungs. So in ARDS patients, their lungs are really stiff. They're very low compliance or very decreased compliance. Their alveoli are not opening up and oxygenating and exchanging gases. So the ventilator can have a setting, the PEEP setting, changed to give them a higher amount of PEEP, or positive end expiratory pressure. All right? So basically what this does is at the end of expiration, so when a patient exhales at the very end, the ventilator gives some pressure into the lungs and helps to open up the alveoli. So this pressure will help to open up the alveoli so that gas exchange can occur. And remember, the reason they need more pressure to open up the alveoli is because their lungs and alveoli are so stiff and damaged when they're in this situation. Circulatory support. So sometimes when patients have higher levels of PEEP on their mechanical ventilator, it puts so much pressure into their intrathoracic cavity that it causes a decrease in the venous return to the heart, okay? So you remember the veins bring all the blood back from the rest of the body back to the heart to start the process over again. And we've talked about the perfusion cycle many times in previous classes. So when you have a lot of intrathoracic pressure, there's a lot of pressure in the chest cavity. So when that blood is trying to return through the veins to come back into the heart to start the cycle over again, it has a hard time doing that because of all the pressure. And if that is happening and all that blood's not coming back to the heart to then be perfused through the entire heart and back out into the circulatory system, and that's decreased, you're going to end up with a decreased cardiac output because you don't have enough circulating blood coming through. And when that happens, your blood pressure falls. Okay, so you have a low blood pressure. So circulatory support means that their cardiac output could potentially be low when they have high amounts of PEEP. And if their blood pressure is low because of poor cardiac output, they might need some, vasopressor support. Okay, so like your vasopressor ICU level meds to help bring up that blood pressure so that the organs and tissues and cells can be perfused adequately. Adequate fluid volume. So these patients oftentimes are on IV fluids. Nutritional support is also important. Patients who are mechanically ventilated, a lot of times we try to initiate some form of nutrition within about 24 hours because nutrition is important to the body's healing process. Prone positioning. So yes, this means your patients who are critically ill and have all these tubes and wires and everything hooked up to them, yes, it means you're laying them on their stomach. And that seems crazy when you think of it because of all their tubes and how sick they are. But it has been found to help open up the alveoli that are in the posterior part of the lungs. So when you lay them on their stomach, it helps to open up those alveoli that were sort of being squished per se when someone is just supine in the bed. Okay, so it helps to facilitate opening of the posterior alveoli, which will then help oxygenation. High frequency oscillatory ventilation, you don't have to worry about. That's just a ventilator mode, a setting that is set for these patients. And low dose corticosteroids can also be used because of the amount of stress that is occurring within the body and the effect on the adrenal glands. So the goal for these patients, you want to oxygenate them, okay? You want them to have adequate oxygenation with a PaO2 greater than 60 and an O2 saturation greater than 90. So a lot of times these patients are going to be on high amounts of oxygen and high amounts of PEEP. Pharmacological considerations. So patients who are receiving this treatment and management for their ARDS, especially if they are on this mechanical ventilation, it can become kind of uncomfortable. So I mentioned earlier that when patients are on these forms of artificial mechanical ventilation, they need some form of sedative to keep them comfortable. Sometimes analgesics to keep them comfortable as well. So you see listed there some sedatives. There are things like lorazepam, midazolam, dexmedetomidine, and propofol. So those are sedatives to help keep the patient quite sedate when they're on the mechanical ventilator. The analgesics like morphine or fentanyl, those can be given to help, just keep them comfortable because having that tube in their throat can be kind of uncomfortable. So that helps with the pain aspect. Another thing, as you see listed there, is the neuromuscular blockades. So these are paralytics. They paralyze patients. And the reason that you would possibly need these neuromuscular blockades or paralytics is because these patients are so hard to ventilate. Remember, their lungs are so stiff, right? Everything's so stiff that ventilator has to sometimes work really hard just to get a breath into these patients because their lungs are so injured and failing and not working as they should. They're stiff. They're full of fluid. So when the ventilator's having a hard time, getting the breath into them that it's supposed to, and you've already increased your PEEP to try to give them more pressure to open up their lungs, and you've already given them 100% of oxygen to try to oxygenate them better, and things still just aren't working, you're still having a hard time ventilating and oxygenating these patients, that's when you need your paralytics. Okay? So these patients are absolutely 100% on a mechanical ventilator. You cannot give paralytics without a ventilator because they cannot breathe on their own when you give them a paralytic. It paralyzes them. So neuromuscular blockades or paralytics, you can see listed there like rocuronium, vecuronium, pancuronium. So these do not give any form of sedation. So write that down because a lot of times people get confused with that. Neuromuscular blockades do not provide any level of sedation. It simply just paralyzes the patient, so they can't move anything. All right? So if you give them just a paralytic and you don't sedate them or give them pain medicine, they're not going to be able to tell you that they can still feel all their pain. So that's why these medications are oftentimes given kind of hand in hand together. If they're getting a paralytic, they're going to be on a sedative, and they could be receiving an analgesic as well. But the big thing to take away is that neuromuscular blockades are used to help increase the compliance of the lungs, meaning make it easier to ventilate the patient. Okay, so they increase the compliance of the lungs, and they do not give any form of sedation. Your sedatives are used to provide the sedation, kind of keep your patient quiet, drowsy, somewhat comfortable looking. And then your analgesics will help with comfort from a pain standpoint. Okay? Nitric oxide can also sometimes be used. So that is a vasodilator that can help with the perfusion oxygenation in these lungs that are so damaged and working so poorly. Okay? Review. I'm not going to go over this because this is something that was taught, I believe, in 1020. But it is important to know, and for the exam, you will be expected to identify basic acid-base imbalances. All right? So this is a little chart that I put together for you. If you kind of need help and need a little refresher, everything's right here in this chart. So one way that I find it easy to remember how you know it's respiratory or it's metabolic acid-base imbalance is respiratory, your pH and CO2 are going to go in opposite directions. For example, respiratory acidosis. Your pH is less than 7.35 and your CO2 is greater than 45. They're going in opposite directions. Metabolic. So in metabolic imbalances, things are going to be equal. So for instance, metabolic acidosis. You look at your pH, it's less than 7.35. You look at your bicarb, it's less than 22. So they're equal. Both components are decreased. Okay? So respiratory, opposite, metabolic, equal, or ROME for short. Okay? ROME to help you remember. So nursing interventions, I've talked a lot about all of this throughout the lecture. Patent airways, number 1. You're going to have to suction as needed. How do you know they need to be suctioned? You listen to them, their lung sounds. You look at their vital signs. And depending what you hear and what you see on your oxygen saturation, their vitals, their heart rate, you determine whether or not they need suctioning. Administer prescribed oxygen. Okay, so you're going to be continuously monitoring oxygen saturation levels with these critically ill patients, and you're going to be monitoring ABG levels quite closely because you want to know their acid-base imbalance. Ensure patent IV access. So these patients are getting a lot of medications, IV fluids, their sedation, their analgesic, maybe their vasopressors, maybe their paralytics. They have a lot going on. So you need good IV access. So this is kind of one of those patients too that you're thinking, okay, I need some central line access for these patients. They're critically ill. Reposition the patient every 2 hours. So when these patients are this critically ill and they're on bed rest and, mechanically ventilated and, can't do anything for themselves, it's up to the nurse or, the care team, nurse and nurse assistant, to reposition the patient so they don't develop bed sores and pressure ulcers, pressure injuries. All right. We also perform passive range of motion exercises. So we don't want the patient, sitting in bed, exercising the legs up and down, moving the arms in and out, because what does that use? Oxygen. It uses up your oxygen demands and increases them. So it makes your heart and your lungs have to work even harder to oxygenate when you're using up all the energy. So you don't want them doing that. They're on bed rest. You want them to rest. And you as the nurse, say maybe when you're doing your bed bath or something, you go in, you take each arm, kind of bend it at the joints, the legs, same idea. But you do it in a passive way that you are mobilizing their joints for them. So that way you minimize oxygen demands. Respiratory care, so chest PT or chest physiotherapy. Sometimes this could apply to patients. So that would be like your percussion vibration that you probably learned a long time ago in one of your earlier classes. Tube feeds, so again, nutrition, help the body heal. Cluster care activities. So you want to allow these patients as much rest period as you can. So cluster your care as best as you can, kind of do sort of a few things at once, and then give your patient a little rest period, and then do some more. VTE prophylaxis, so that's like your DVT prophylaxis, so that's your subcutaneous heparin, subcutaneous Lovenox. That's part of the ventilator-associated pneumonia bundle. Provide meticulous skin care and oral care, right? So oral care should be about every 2 to 4 hours. And you want to do that so that you're removing any bacteria in the mouth that could be aspirated into the lungs. Provide emotional support because this is very stressful for both the patient and the family members. Alternative communication means, so I talked about that, communication boards, a whiteboard, a piece of paper and a pencil on a clipboard, asking yes/no questions so it's easier to communicate needs, finding a way to communicate with your patients. Assist with weaning from the ventilator. So that is your breathing trials, the spontaneous breathing trials. So the physicians will determine whether or not they want the patient to undergo a spontaneous breathing trial. And that is, again, part of the ventilator-associated pneumonia bundle. So the sooner we can wean the patient from the ventilator or get them off of the ventilator, the better, because then their risk for infection and complications will be less. The longer they're on a ventilator, the higher risk for complications. Okay? So we do the breathing trials as ordered by the licensed provider. Go through all these expected outcomes, but they're all listed there for you. And same thing with the nursing diagnoses, they're just there for you to look through. So some key points again, because I know this is kind of a big lecture, but I hope that I explained it in a way that kind of helps you to understand the significance of a complication like ARDS, because these patients are so critically ill. And I know that you guys aren't caring for critically ill patients, but if you end up in a work environment like an emergency room or something, you might come across these patients who come in because you don't know what can come into an ER. And you need to kind of know the basics of what are the main big important things to know. And I know that the NCLEX blueprint does mention, care for patients with mechanical ventilation, artificial airways, and also, like the ventilator-associated pneumonia bundle, because they like to prevent complications. So your key points. So hypoxia versus hypercapnia. So hypoxia, that's the low PaO2. So that's the arterial O2 levels. Hypercapnia is the high PaCO2. So that's arterial CO2 levels. So hypoxia is low PaO2, hypercapnia is high PaCO2. And remember, thinking back to like classification, like what is respiratory failure in terms of our pH, our O2, and our CO2. The pH is going to be less than 7.35. Your PaO2 is going to be less than 50. And your PaCO2 is going to be greater than 50. So that's kind of your classification for respiratory failure. Mechanical ventilation. You have non-invasive, which is your BiPAP, your CPAP. Okay, CPAP, someone has to be breathing spontaneously. That's like your patients who are well, living independently at home, maybe use it for obstructive sleep apnea, or maybe it's your heart failure patients in the hospital that just need a little extra pressure to breathe and adequately ventilate and oxygenate. Your BiPAP is a little bit kind of like your higher level. So CPAP is at the bottom, your BiPAP sort of in the middle, because it gives you that pressure to help with your breathing and also has that respiratory rate that it can deliver a breath if the patient does not take their own breath. And then if that has failed, so BiPAP's in the middle, then it goes to your invasive ventilation. So invasive is the artificial airways, like your endotracheal tube mechanical ventilation. Pressure alarms, so those are important to know. You have your low pressure, so that's a disconnection, a leak somewhere within the system. Your high alarm, there's an obstruction somewhere. There's a kink. Somewhere is blocking the breath that is trying to be delivered. That's your high pressure. So if you cannot determine what is causing your low or high pressure, you need to disconnect the patient and bag them with the ambu bag. So deliver breaths with the ambu bag manually. And apnea alarms, so that's like your breathing trials. So apnea alarms going to let you know when your patient's not breathing enough or not at all. Your nursing care. So I kind of just talked about this on the previous slide, everything I went through with nursing interventions and nursing care. But your VAP prevention is important to know because it is part of preventing complications. ARDS. So your causes and risk factors. So what are those? Big things would be like severe trauma, the aspiration story I told you about, sepsis, maybe an infection that then turns into sepsis, or very large major surgeries, prolonged inhalation of high concentrations of oxygen or smoke or corrosive substances, okay? PEs, pulmonary embolisms, whether they're air or fat. Okay, there are many different causes, but think of it as some sort of injury to the lungs. Clinical manifestations. So what's kind of like the classic symptom I talked about? The infiltrates on the x-rays, right? So they have the whiteout or kind of fluffy white appearance in their lung fields on the x-ray when it should be black. Right? When we look at a normal x-ray, the lungs should look black. But in these patients, it's whited out. It's all this fluffy white material in their lung fields. So that's a classic symptom. They're going to have severe hypoxia. They're going to be tachypnic, tachycardic, probably hypertensive initially because of the hypoxia, right? They're going to have decreased lung compliance. Their lungs are stiff. They cannot ventilate adequately. They're going to have poor alveolar perfusion. They're not going to have adequate gas exchange in the alveoli. Okay, that kind of goes hand in hand with the severe hypoxia. All right. So these patients are going to look like they are in a great deal of distress. Your treatment, so mechanical ventilation. Most oftentimes, if it's a situation where they are in ARDS with respiratory failure, they're going to be intubated with an endotracheal tube with the mechanical ventilation. And what do we want to administer? High amounts of oxygen, right? So sometimes, patients may need 100% of oxygen for a long time, and then we start to slowly wean it down when they can tolerate it. But initially, they need a lot of oxygen. And they need a lot of positive end expiratory pressure in the mechanical ventilator settings, the PEEP. High amounts of PEEP. Because what does PEEP do again? It helps to open up the alveoli that are damaged and fluid-filled and not working. It helps to open them up by giving an extra bit of pressure at the end of expiration, in hopes that the alveoli will be able to adequately exchange gas exchange. Okay? So what else? So you have your mechanical ventilation, endotracheal tube, your PEEP, your oxygen. If you have high amounts of PEEP, what's going to happen to your blood pressure? It's going to go down. Okay? You're going to have poor cardiac output when you have high amounts of pressure in your intrathoracic cavity. And that results in low blood pressure. Okay? You also want to provide them nutritional support. Okay? Because you need their body to heal. So your goal is to maintain an O2 sat greater than 90% on the lowest amount of FiO2 or oxygen that you can. You want these patients to be able to oxygenate well. Okay? Because in acute respiratory distress syndrome, they are not oxygenating well at all. So your goal is to increase their oxygenation, improve their oxygenation, increase their lung compliance. You want their lungs to function better. You want them to be able to ventilate adequately and perfuse adequately. So what are some things we can give to help increase lung compliance? Well, sedation could possibly help, right? Because it's going to keep the patients a little bit calm, sedated. But if that's not working and we're still having a hard time ventilating them, we're going to look to the paralytics. The neuromuscular blockades will help to increase lung compliance. It's going to make it a little bit easier for the mechanical ventilator to deliver the breaths to the patient. And they'll also get some analgesic effects because remember, the neuromuscular blockades do not provide any level of sedation or analgesia. They are just paralytics. They only paralyze. So you need to give something else along with it, a sedative and or a pain medication. Your nursing care, so we talked about that on the previous page. Everything's listed there. So you can refer to that in ABG interpretation. So again, you will be expected to interpret basic ABGs for the exam. All right, so you could use that chart if you like the chart on the previous slide, or use your old notes from 1020, whichever way you would like. But you will be expected to know, like the different acid-base imbalances. Nurse is caring for a patient requiring mechanical ventilation due to ARDS. The nurse understands which of the following are a component of preventing ventilator-associated pneumonia. Select all. So it's going to be B as in boy, C as in cat, E as in elephant, and F as in Frank. So B, C, E, and F. So A would not be correct because the head of bed says less than 30 degrees. We want their head of bed greater than 30 degrees. D would be incorrect Because remember, with VAP prevention, we want to wake them up. We want sedation vacations. So we don't want to sedate them with a benzodiazepine. We want them to be awake. So that's why that's incorrect. For a patient with the following vitals: temps 101.2, temporal artery, heart rate 113, respiratory rate 36, blood pressure is 98/47, O2 sat is 84% on room air. Which of the following would be the nurse's first priority? So it would be C, as in cat. So apply 100% FiO2 via non-rebreather mask. Okay, so non-rebreathers are the only type of mask that can provide 100% of oxygen to patients. So when you have someone who has an O2 sat of 84% on a room air, you need them to get some oxygen. So 100% non-rebreather is what would be your option here. The nurse is caring for a patient who is just intubated with an endotracheal tube for severe respiratory distress related to ARDS. Which of the following interventions would be the priority of the nurse? So the priority would be B, as in boy. Auscultate breath sounds bilaterally. So once that tube goes in, you want to listen to be sure that it's in the correct place. You don't want it to be in the esophagus, right? So you have to listen for breath sounds and hear that the tube did indeed go into the trachea. And then you'd follow with the rest of the options there, okay? Following ABG results, you have a pH of 730, PaCO2 of 48, PaO2 of 80, and HCO3 or bicarb of 25. So remember the acronym ROME, respiratory opposite, metabolic equal. So in this instance, your pH is down, your PaCO2 is up. So they're opposite. Respiratory acidosis, B. Interpret the following ABG result: pH 7.5, PaCO2 of 40, PaO2 of 88, and bicarb of 29. So when you look at your numbers, your pH is high and your bicarb is high. So what would that be? C, as in cat, metabolic alkalosis. All right. So I believe that's it for this lecture. Please, watch the chest tube portion in the separate little PowerPoint lecture there on e-learning. And when you are done listening to both, just remember to finish the assignment that is under the forum section on the e-learning site as well. That way you can get attendance for this lecture. Okay? Please let me know if you have any questions. You can email me at any time. And I also would like for you to have all of your discussion board submissions complete by Sunday night at 11:55 p.m.